Dr. T. Basu, Professor, Department of Pathology, MGMCRI, Pondicherry. We have students joining us from across the country from various medical colleges. Kindly introduce yourself, students.
I am Dr. Shreya Chatterjee, third year PG resident from Shri Krishna Medical College and Hospital, Muzaffarpur.
Good evening, everyone. Myself Ankita Bharti. I'm a third year resident and from Dr. PMC Medical College, Amravati.
Good evening, everyone. Myself Rick Ghosh. I am from JNMC, ANU.
Good evening, everyone. Myself Dr. Jaiskumar Tiwari, PG second year, GMC, Amritsar.
Good evening, everyone. Myself Shivani, PG year 2, CMC Ludhiana. Good evening, everyone. Myself Vashi Sharma, second year resident from SDM Jaipur.
Good evening, everyone. I'm Dr. Shomishna Das, SSCH, Assam, third year resident.
Good evening, everyone. I am Basundhara, second year PG resident from KMC, Mangalore.
So all the students have introduced themselves. Dr. Gitanjali, I think she has not joined. Okay. So
Gitanjali has joined, but she's, I think, had an issue. She's joining back.
Okay. So the moderators today for this session is myself, Dr. Deepika Chatterjee. I'm fellow cytopathology from St. Medical College and AM Hospital, Mumbai. And my co-moderator is Dr. Mimi Ray, Associate Professor, Non-Bengal Medical College, Siliguri. Our webinar hosts are Dr. Amita Borges, Consultant Pathologist, Center for Oncopathology, Tata Trust, Mumbai, and Dr. Sumit Ujwal, Professor, Department of Pathology, Tata Memorial Hospital, Mumbai. Something to remind you of, if you face connection interruption, low or no sound, video freezing, or video lag, kindly leave the meeting and rejoin with the same link. If the problem persists, please check the internet connection. Number 2, please answer the poll questions, if any, by typing in the chat box. And number 3, please do not send any requests for annotation to the presenters because it disturbs the presenters. There are certain disclaimers, kindly go through it. Some more disclaimers. The upcoming talks for this session, for the next session is exam going MD students, cases of Hemat, Histo and Cyto by doctors Mrinalini and Kalyanpan. This will be aired on 2nd July 7 p.m. And on the 4th of July 7 p.m. There will be slide seminar, head and neck cases, Cyto and Histo by doctors Chatura and Ramaswamy. So let's start. Dr. Deebasu, the stage is yours.
Yeah, good evening, everyone. Just give me a minute. I'll share the slides and then we will start. There are about 11 cases that we will discuss. Is the slide visible?
Yes, sir.
Yes, sir.
Yeah, Basu.
Visible to all?
Yes, sir.
Yes, sir.
Hello?
Yes, sir.
Okay, great. And I'm also audible, I hope.
Yes.
Right. So what we will do in this next few minutes of maybe an hour or so, we have 11 cases and I had... One second, yeah.
Click in the center.
It's moving there.
No, just click in the center of the screen. Now click neck, not remove. Just click in the center and then use your
yeah,
cursor.
okay. Got it. All right, basically, yeah, we've got 11 cases and these are common cases, simple cases which many times come for the exams. So I hope all of you have gone through them and we will start with case number 1, right? So in some of the cases, I've given very little history. Maybe we will add on to the history or you will provide me the history depending on what you think in the slides. All right, so let's start. So the first case is that of a 17-year-old girl whose hemoglobin was 8.5. Okay, maybe Shreya, can you start?
Yes, sir.
Right, Shreya, good. Let's what did you see in the slide that I had sent across?
So this is a peripheral blood smear picture which shows microcytic hypochromic cells showing anisopoikilocytosis with few pencil cells are seen and few polychromatic cells are also present. No nucleated RBCs are seen on the smear. And I think one lymphocyte and the platelet on this smear appears to be adequate.
Right. Why do you think I've sent a picture of the lymphocyte?
Sir, to compare the RBCs, whether they are normocytic or microcytic, so that we can compare it with the nucleus of the lymphocyte.
Okay, great. So basically, you think any other comment on the number of RBCs as such in the fields?
So
three slides, right? Yeah.
Yes, sir, it appears reduced, sir, as there is too much spacing between the RBCs. There should not be that much space, and these appear hypochromic to be.
All right. So what was your impression?
So this is a microcytic hypochromic blood picture due to hemolytic anemia, and most probably, sir, because of the age group that is 70.
One sec. Why hemolytic anemia? Microcytic hypochromic blood picture. Most probably, you said hemolytic anemia. So what are the features of hemolytic anemia that you saw in the slide?
Yes, sir, I'm mistaken. It's not hemolytic anemia. Microcytic hypochromic blood picture due to a deficiency anemia, according to me, which is most probably because of the age group that is 17-year-old female. I would say it would be iron deficiency.
Yeah, I hope you're very clear about that. This is not a hemolytic picture.
Yes, sir,
this is generally microcytic hypochromic RBCs, right? So be careful when you say things. Yes, right. So 17-year-old. So what is okay? Fine. I'll show you some more further history that we have about this case. 17-year-old schoolgirl, feeling of weakness and lethargy for the last 1 year, poor performance in class, and as anticipated in adolescent age group, she had a menarche at 14 years of age, but she's been having menometrorrhagia, increased bleeding during the menses since then. So that's 2 plus pallor, no jaundice and no organomegaly, right? So this is usually the picture of what we get in an iron deficiency anemia, right? Okay, so I'll show you some more pictures. Okay, now this, can you interpret this?
So here we see hemoglobin is 8.5 gram per day, which is of course less. So it is showing.
Means specific. It's anemic.
Yes, it's anemic.
Mild, moderate, severe.
So I would say moderate.
Okay, fine.
Sir, here I can see that MCV is reduced, and MCH is also reduced. Sir, MCHC is also reduced. The red cell.
Shreya, can you quickly tell me why did you say it's reduced each of them? What is the lower limit of an MCV?
Sir, the MCV in the normal value stands from 80 to 100
right.
For MCH, it stands from I think 32 to. Sorry, 27.
Yeah, others are right. It's in the 20s, 27 to 32 or so. Fine.
So, and sir, MCHC stands from 32 to 36.
Yeah, roughly around 30 to 32, 34. That's the MCHC. So all the 3 things are reduced. Which of the parameters in this is important, critical, when you're dealing with a microcytic hypochromic case?
So I think the Sir, I
Anyone else? Anyone else? Which one do you pay attention to first?
So we pay attention mostly to the MCV and the rate cell with distribution, sir.
Okay, so you look at
here
the
we
MCV. MCHC,
and we
mind you, is one of the last things to go down in iron deficiency anemia. So you may have iron
Yes, sir.
deficiency anemia with a normal
RBC counts.
MCHC.
RBC
RBC count
count
is
also,
low.
RBC
RDW, what
count.
is that? Okay, one by one. Yep. Let's continue with Shreya. What is this RDW?
Sir, the RDW is not in this it is 18%.
What do you understand by what does RDW stand for?
Sir, the red cell differentiation basically
Red cell? Red cell?
red cell width, sir.
Distribution width.
Distribution width.
Distribution width. Okay, let's say distribution width. And what does it measure?
So it is the difference in the like the sizes of the cells, how different they are from each other.
Okay, so it basically talks of the anisocytosis, right? The mean corpuscular volume. It's a part of the anisocytosis. Yeah, very good. Okay, so what is 18%? What do you understand by that? Is it normal or is it increased or decreased?
Sir, it is increased.
Right. It's increased. So the normal RDW is roughly
So it should be less than 14.
approximately 13 to 14%. Yeah, you should remember that. So we'll come back to this little points when we discuss it further. What is the RBC count?
So it's reduced here. It's 3.6
So
million.
RBC count is also reduced. So fine. Your points are well taken. Low hemoglobin, moderate anemia with a low MCV, MCH, MCHC, RDW elevated, and RBC low. All right. So now I hope all of you are familiar with looking at the histogram. And so anyone else? Okay, Ankita, are you around?
Yes, sir.
Just can you look at this and interpret? First, the CBC is another case. Okay, there's another case. So again,
Okay. So here the WBCs are in the normal range.
yeah, let's stick to
RBC,
the RBCs. Let's stick to the RBCs.
okay. So RBCs are in the lower range. They are a
Right.
little decreased, and hemoglobin is decreased, suggestive of anemia. Hematocrit value is increased. MCV is
Hematocrit
decreased.
is increased. Hematocrit.
Sir, it is normal.
What is hematocrit?
Sir, it is the dilution.
Hematocrit. Anyone else? What do you understand by the term hematocrit?
Pack cell volume.
Yeah, it is equal to the pack cell volume.
Pack cell
Hematocrit is the machine gives us a hematocrit. Pack cell volume is when you actually pack it with an intro tube, centrifuge it. So it's equal to the pack cell volume. So what is the normal pack cell volume?
36 to 48%.
Yeah, and related to the hemoglobin, is there some kind of a ratio?
Yes, sir.
Yeah,
3 times plus minus
Very good.
3.
So there's this rule of 3 that we always have. RBC into 3 is the hemoglobin into 3 is hematocrit or pack cell volume. Kind of, this is what we look at generally. Fine, very good. Yeah, so Ankita, go back and tell me about the MCV, MCH, and MCHC.
Sir, MCV is decreased.
Right.
And MCH and MCHC both are decreased. Platelets are normal, and RDW appears to be increased.
Is increased, not appears to be, it is increased.
It is
30%.
increased.
Okay, the CV part of it is quite increased. Okay,
Yes.
are you familiar with the histogram? Interpreting the
Uh,
RBC histogram?
Sir, roughly. Sir, this hemogram
The
shows
dark
that
blue is the normal, expected normal. Yeah, so
and the
the
light blue is shows that the RBCs are decreased.
are
Decreased.
we don't use the word decreased. What else do we use when you look at the histogram? What is this? If you drop a line from the peak straight down below,
Sir,
The size
that's
of
the mean corpuscular volume. So this is kind of shifted to the left. This indicates it's microcyclic, right? It's microcyclic. Okay, I hope you're all aware. If you're not, please familiarize yourself, because apart from this, you might also be given these charts, histograms to interpret. That's also part of our routine learning, because once you know this, your case diagnosis is easier. Okay, so all of you, I hope you're aware of it. The mean corpuscular volume, when you draw a line straight from the peak to the base, this is the size in femtoliters. And okay, so mean corpuscular volume should have been here, has shifted to the left, right? So that indicates microcytosis. We will not go further into details, but yes, we will discuss this later. Okay, fine. So what are the possible questions that will come when you get a slide? No, the slide of a microcytic hypochromic iron deficiency anemia may seem a very simple slide, but many a times examiners keep such slides so that we understand that at least you know your basics clear. Okay, so these are questions that will be asked. What is microcytosis? You explain that. What is hypochromia? When do you say a red cell is hypochromic on the morphology?
More than 1/3 of central
Central
pallor.
Okay, all of you know that, I'm sure. Good. The central pallor is more than 1/3. Perfect. So now tell me some of the causes of microcytic hypochromic RBCs.
so sideroblastic anemia, iron deficiency anemia,
First cause, always
Iron
research
deficiency.
order of
Deficiency anemia.
Iron
important.
deficiency
Okay,
anemia.
iron deficiency anemia. Next,
thalassemia, sideroblastic
Thalassemia.
anemia, and anemia of
Okay.
chronic disease.
anemia of.
Chronic disease.
Chronic disease.
Okay, what is the current designation of anemia of chronic disease? What do we refer it like? Anemia of chronic disease is a very vague term. So basically, anemia of inflammation. Okay, anemia of chronic disease includes liver disorders, kidney disorders.
Kidney disorders.
Those now, because of their pathogenetic differences, would better be labeled as anemia of renal disorder, anemia of liver disorder, anemia of malignancies. Okay, so generally, inflammation and malignancy come as what we used to call as anemia of chronic disease. Yeah, so those are the causes of microcytic hypochromic RBCs. Generally, when you're dealing with a case, what are the differential diagnoses of microcytic hypochromic anemia? What are the other common differential diagnoses where you actually have a problem?
Thalassemia.
Anyone? Yes, Sonisha, you'd like to say something?
Thalassemia, sir.
Thalassemia.
Thalassemia.
Thalassemia, sir.
Thalassemia with what?
With
IV.
With the high
Let's all of us not try and answer. Okay, I'll point out. Somisha, what is your DD of thalassemia with?
Sir, iron deficiency anemia with thalassemia, sir.
Okay, which type of thalassemia? You really
Sir,
have a
beta
problem.
thalassemia and
Beta thalassemia, not with alpha.
thalassemia trait, sir.
Trait, right. So at times we have confusion of any iron deficiency anemia with thalassemia trait. We also can have confusion with iron deficiency anemia versus anemia of chronic disease or inflammation. Okay, so let us understand that. What do we mean by microcytic hypochromic RBCs, or what do we mean with the differential diagnosis of microcytic hypochromic anemia? See, thalassemia major and iron deficiency anemia are not really differential diagnosis, because clinically, morphologically, they are two separate entities. Okay, so we are puzzled when we are dealing with iron deficiency versus thal trait, times iron deficiency with anemia of chronic disease, and we have certain parameters by which we differentiate. Yeah, I'm getting good answers on the chat. We will discuss that in a while. All right. So Ankita,
Yes.
so how do you diagnose iron deficiency anemia? Apart from the smear, what are the other modalities that you have?
Sir, clinically,
No, not clinically. Clinically, yes. Clinically, we'll come to that. But laboratory diagnosis of
sir,
iron deficiency.
the iron profile of the patient.
Yeah, tell which ones are important and which ones.
Sir, serum
Which iron
iron,
profile would you like to do?
serum iron, serum ferritin, and TIBC.
Given a choice, okay, given a choice, you can do only one test. Which one will you do?
Sir, TIBC.
TIBC. Anyone else has any other opinion?
So serum ferritin.
Ferritin.
Right. We start with serum ferritin, because if serum ferritin is low, less than 15 nanogram per dl, then it is iron deficiency anemia. Right.
So
But any problem with serum ferritin?
In inflammation, sir, serum ferritin will be
Yes.
increased.
So serum ferritin is increased it's an acute phase reactant. So it can rise in inflammatory conditions, any malignancies. It's an acute phase reactant. So if we do a ferritin and find that it is low, there is nothing else to be done. But in the presence of inflammation, which many of our patients have, chronic inflammation, tuberculosis, a ferritin level can be not so low, can be elevated. So there, in some situations, WHO says if in the presence of inflammation, if you have a ferritin less than 50, take it as iron deficiency anemia. Okay, so ferritin we do. If your ferritin is equivocal, you're not sure, then you go ahead and do your other lab profiles. Okay, so also whenever you diagnose an iron deficiency anemia, always have a look at the retic count. It's usually a hypoproliferative. So retic is on the lower side.
Lower
Right?
side.
Ferritin, any other parameters? Now these three that we commonly do, generally we give an iron profile and everything comes. Serum iron, I've written down the normal values, but it's very unpredictable. It's a very labile thing. So you eat a lot of iron-rich food and give your blood, your iron levels will go up. What happens to TIBC?
Increase.
It's increased, right? In iron deficiency, pure iron deficiency anemia, it's increased. Transferrin saturation is another thing where in iron deficiency anemia it is reduced to less than 10%. So these four things can, in permutation combination, can give you a diagnosis. Okay. Free transferrin receptors, another important useful test where it is again elevated. Increase in free transferrin receptors is another feature. Ratio of free transferrin receptor to log of ferritin. That's another parameter which we can directly get from our results. 1.7 or more is indicative of iron deficiency anemia. Any other parameters your cell counters give currently? A newer cell counter?
Any side protein.
Are you aware of these? I mean, if you use the newer, you can get a percentage microcytosis, percentage hypochromia, and very important is a parameter that's useful is reticulocyte hemoglobin. Okay, just read up about these because there's not much time to. I'll run out of time. Reticulocyte hemoglobin is a parameter some of our cell counters give, and that indicates early iron deficiency. It's an indicator of early iron deficiency. Okay, the hemoglobin actually in a reticulocyte is measuring the amount of hemoglobin, so that's a useful indicator. Right? Okay. Now, okay, Vijay, since you're there on screen right in front of me, is diagnosing iron deficiency enough? I've given you three scenarios.
Yes, sir.
So what do you think? I diagnosed iron deficiency, started on iron, but the child doesn't improve. What would you think of what doing?
Sir, malabsorption of iron.
Yes, so understand iron deficiency anemia is actually basically, if you look at it, it's a symptom. There is some cause to it, right? So unless you treat the cause, you will not be able to handle the patient, right? You will not get a good response in the patient. So if you have a 6-year-old boy with a history of pica, low hemoglobin, iron deficiency, what is the likely cause for an iron deficiency anemia in a child?
So in worm infestation.
Very good, worm infestations. Okay, so just do a stool examination or deworm the child, and I'm sure in most of the cases your response will be good, and that's what we want. Just don't want to diagnose a disease. We need to find out the cause and then treat the cause. Similarly, in the second case, a pregnant lady has come in labor, feeling tired, and again iron deficiency anemia with a hemoglobin of 3. As a pathologist, would be enough for you to just say, okay, she's got iron deficiency anemia. But any other suggestions you would like to do? What do you think this lady would need? She's in labor. Transfusion. Yes, you must be aware that such a patient needs a transfusion. She may even need parenteral iron therapy. Okay, so it is not enough to just say this iron deficiency anemia and start the patient. Anything about the baby who's born? Yeah, Ankita, Thal, we have ruled out. I'm calling all of these as iron deficiency. Anything you would like to look at the baby with the mother having a hemoglobin of 3?
Compatibility.
Are you checking compatibility?
No, not necessarily. The baby will also be iron deficient. So you might even want to start the baby on iron supplementation as early as possible. Okay, so because the iron stores are not there in the mother. So such patients may need prolonged iron therapy more than the recommended 3 months. They may need more, and the baby may also be investigated for iron deficiency. Okay, insist that okay, because that's important. What about the third case? 74-year-old man, what would you like to investigate?
So any bleeding history.
Yes,
Like
So
hemorrhage.
what test would you like to do?
Occult blood.
Very good. You'll do a stool occult blood. All males, colonic carcinoma or gastric carcinomas could be the first manifestation of by which they present is as iron deficiency anemia. Okay, so that's very, very important. Elderly men, postmenopausal women, rule out an gynecological malignancy. So that's important when you're diagnosing iron deficiency anemia. All right. So this is what we would like to do. Fine. Just another case. Quickly, we'll go through this. The 25-year-old woman with a hemoglobin of 10.7, and that's the smear. Gitanjali, are you around? Or okay, are you there? Have you joined? Okay, Shivani.
Yes, sir.
Yeah. Can you tell me quickly what do you see here and differentiate it from the previous slides that I had shared?
So there is a ruler formation here. The RBCs are arranged.
Just talk of microcytosis, hypochromia, and the number of RBCs.
The RBC number is increased.
Appears
And
increased.
compared
Okay,
appears
right.
increased. Comparing to the nucleus of the lymphocyte, the size of the RBC appears to be smaller.
Right.
And appears to be hypochromic also.
Anything else you see in this slide?
The targets.
Targets.
Okay, so hypochromic microcytic with target cells. Here and there a few elongated cells, right? Another one. Right? So
Yes, sir.
what do you think would be the history of again another cause of microcytic hypochromic?
Thalassemia.
This what type of thalassemia? Major or minor?
Minor.
Minor.
Don't say beta. On a smear, we cannot tell whether it's beta or alpha. Okay, even alpha thal will look microcytic hypochromic, but this is obviously not what you see in a major or even an intermediate. These are all subtle changes, microcytic hypochromic target cells. So this was the case. She was recently married. She wants a family to be planning a family, and the hemoglobin is actually good, not too bad, 10.7. Okay, what do you see here? Okay, Rick.
It is increased.
RBC
Anyone? Yeah.
cell mass is increased, sir. MCV
That's increased, right?
yes, sir. Yes, sir. MCV is reduced. MCH and NCH is reduced, sir. And RDW is in normal levels.
Okay, so what do you think when you get a CBC report like that? What is your first thought?
So first, we have to differentiate from the idea. So quickly we can do the mental index and we can find out.
Even before you do a Mensa index, what are the odd points?
Rule of 3, sir.
RBC count is high, sir. You can
ICC count is high, right?
Count is high, sir. Yes, sir.
Ruler formation, so we can incubate the blood and see the ruler.
Rule formation we are not bothered about right now. Looking at the CBC, you see that the RBC count is high.
RBC count is high,
There is
sir.
a marked disparity
MCV is
between
low.
Disparity between the
hemoglobin of 10.7 with an MCV of 61. This kind of discrepancy is something again you will think of. All right, so these are 2 points that first look, even before you start counting your Mensa index, seems out of proportion to what you saw in an iron deficiency anemia. Iron deficiency anemia, RBC is low, and the MCV that reduces goes kind of hand in hand with the hemoglobin.
Hemoglobin.
Okay, so an iron deficient anemia with an MCV of 61, I would expect the hemoglobin to be about 8 or 8.5 or so, right? So this stark difference and the near normal NCHC and the normal RDW all points towards a thal trait. Okay, so these are 2 cases. What we read, the differences, and then yes, all of you were jumping the gun with Mensa index. Yes, it's useful. but it is not the only way to differentiate the two. Okay, you can land into a problem because that beta thalassemia in Indian population may be associated with iron deficiency anemia. It's common. Associated iron deficiency anemia and beta thalassemia. Okay, so a Menzer index may not always be good, it is useful. But even before you calculate, you should have an idea that this is okay. So this is how I've written the differences between the two when you look at. And so what would you do, Rick? Case 1A and case 2. How would you diagnose iron deficiency in this particular case? What would you do next?
Next, you can go for HPLC, and
in both the cases, you would like to do an HPLC?
No, sir.
no, sir. No, sir.
It might land into trouble. Retic count is low in both the cases. Retic count is not very elevated in calibrate. Okay, so retic count may not help. So in the first case, as we discussed, let's do a ferritin. Histograms are the same. Ferritin and ferritin comes low. In the second case, I would rather do an HPLC. Bone marrow is probably not needed. Mega. We don't do bone marrows in such a straightforward microcytic hypochromic anemia. It can be diagnosed even before. So in case 1B, what would you do? HPLC, right, Rick?
Yes,
What would you expect in HPLC if it's a beta thalate?
HbA2 will be raised.
HbA2 will be raised.
Yes, HbA2 will be raised. How much raised?
More than 3.5, sir. More than 3.5.
3.5 to
40%, 40%, 50%. Is that okay?
yeah,
Yes, sir.
32.
Okay, you can have a
No, sir, up to 9. 3.
yeah, up to 9%.
9.5 to 9%.
Beyond that,
9%.
okay, suppose it's 30%, what's your diagnosis? HbA2 is coming as 30%.
HbE, sir.
Right, perfect. HbA2 and HbE covolute together in an HPLC. So it's HbA2 to be elevated for beta thalate is about 3.5 to about 9%. It does not cross 10%. If it crosses 10%, think of HbE. Okay, now this particular case, you do an HbA2 and it comes out as about 1.5%. What's your thought? HbA2 in this case is 1.5%. What's your thought? Anyone? What are the causes of low HbA2?
Alpha thalassemia.
Okay, one alpha thalassemia, fine. Second, iron deficiency anemia.
Iron deficiency.
Coexisting iron deficiency anemia. Okay, so if your HbA2 is not as high as you're expecting it to be, and it comes low, what generally we do is we supplement iron and repeat HPLC after 3 months. So that's again pretty common in our country. Okay, so we do an HPLC and we find the HPLC. Okay, so that kind of finishes. I know there are a lot of unanswered questions. We'll try and discuss them subsequently sometime later, or in the chat we'll discuss it out. Okay, case 2, who's going to describe?
So I can.
Okay, go ahead, please.
So this is a 14-year-old boy, Eller and recurrent jaundice since early childhood. On examination, Eller HLS 5 centimeter and HB 8 gram per deciliter.
Right. So you have provided some slides.
Yes, sir. So in this, an isocytosis is there, macrocytes are there, and spherocytes are also there. And and also adding to the history, like patient is presenting with jaundice since childhood, with recurrent jaundice, and spleen is also there. So it appears to be hereditary spherocytosis. Sir.
Okay, fine. So let's not again jump the gun. We just look at appreciate the spherocytes. You call them spherocytes because they are small,
Yes, sir.
smaller than the rest, and kind of hyperchromic. They don't have a central color, right? That's why you call them spherocytes. Fine.
Yes, sir.
Another one. This again, I think the picture was shown to you. Another one.
Yes.
Right. What does this slide show, Shivani?
So this slide also shows some spherocytes are there.
Right. Right. Anything else?
Okay.
NRBCs are also there.
There's a nuclear NRBC, right? There's a nuclear NRBC. Perfect. So there is some degree of hemolysis going on, not too much. There are not too many polychromatic cells in RBCs. Okay, so how would you report on this slide? Impression, what would you give?
So in impression, an isocytosis with
All
macrocytes.
that is there, all that was findings. What's your impression? What are you going to tell the clinician or the patient?
So for me, it is hereditary
Sorry.
spherocytosis.
Hemolytic anemia.
Hemolytic anemia, straight away. Okay, what hemolytic? That's a very vague terminology, and I do not think I could report this as a hemolytic blood picture. I don't see polychromatic cells enough to call it hemolysis is not available. Okay, so how do you report on this?
So peripheral blood smear showing features of spherocytic blood picture.
Right, stop at that. Peripheral blood smear shows features of a spherocytic anemia. Okay, let's stop at that. And as someone in the chat is saying, what are the causes of looking at spherocytes, of getting spherocytes in the smear?
So there is the RXL membrane defects are there, and
Okay,
thyroid.
hereditary spherocytosis is one. Fine.
Autoimmune
Any other?
autoimmune.
Any other thought when you see spherocytes?
Transfusion reactions.
Very good. Transfused RBCs. No, recently transfused RBCs may mimic a spherocytic anemia. Okay, so there you have, when you get a transfused RBC, generally there is this two population of cells. One are spherocytes, very small, often cremated, because they're old RBCs, stored RBCs. And in the background are generally either a microcytic hypochromic picture. So you have a distinct double population. And if you look at your histogram, often that double peak comes. So someone was asking whether when we do not get adequate history, these are the things that will make you suspect that, okay, maybe I'm dealing with a transfused RBCs. Double population, double peak, and then you can check with the clinician that whether a transfusion has been given or not. Okay, usually transfused RBCs will not show a hemolytic picture in the background. Okay, you won't have much of hemolysis in the background. Okay, so these are the three things that we generally rule out. So what would you like to do?
Home
In a
stay.
picture like this, what should you do?
DCT.
Yes,
Home stay.
that's very good.
DCT.
Start with, though the history is there of a childhood jaundice, splenomegaly, you think it's a hereditary spherocytosis, it's good to do a Coombs test. Okay, that's generally the first thing that we stick around. So these are some of the other investigations that's available. Again, RBC low, MCV is on the lower side, MCHC. Its textbook says that hereditary spherocytosis is probably one of the causes that MCHC is elevated, more than 35. But in our experience in Indian population, because of probably coexistent iron deficiency anemia at a large scale, we generally don't get a high MCHC in all the cases. So we keep that in mind. That no textbooks say MCHC is usually very high. Yeah, Western population it's very high. But in Indian population, we generally do not see a very high MCHC. So what else would you like to do now? Yes, as you said, two more findings that help us. It's an indirect hyperbilirubinemia, ultrasound showing gallstones. So all these let us tell us that this is possibly a inherited disorder. But in spite of that, please do a Coombs test. DCT is negative. So once you have a DCT negative, you can think of that. Yes, I'm on the right track. I'll be dealing with hereditary spherocytosis. So Shivani, how do you diagnose? What further tests would you do for hereditary spherocytosis? Yes, osmotic fragility test. Remember that osmotic fragility test is a non-specific test. All causes of spherocytosis will show a shift to right in the osmotic fragility test. Okay, right?
Yes.
Osmotic fragility test is a very non-specific test. So you done a DCT and you do an osmotic fragility test. Okay, fine. Any other history? Yes, you will take all these history. Often, this is important. Women with bad obstetric history. Often the spherocytosis in adults causes bad obstetric history. Right. So what next you will do? An family history, osmotic fragility test. Are you aware of what is this incubation fragility test?
Yes, sir.
Yeah, tell me.
Yes, sir.
What do you mean by incubation fragility test?
Blood is
Simply
incubated.
So volatility is incubated for 24 hours and then you repeat
In
the
practice,
test.
76
In fresh blood, the osmotic fragility test may not be shifted to the right. There are few spherocytes, so it may not be. So you incubate the blood at 37 degrees, and after 24 hours, repeat the test, and that shows the shift to the right becomes more prominent. So the mean corpuscle of fragility is more prominent there. Any other test that we do? It increases, yes.
No, sir.
Any other test that we can do?
Finding.
If you don't have EMA, you can even do a flow cytometric osmotic fragility test. Flow cytometry is possible, and EMA binding. So these EMA binding. Right. So these are some things that you must know. I mean, we will not go into the details for some time, but this is how you will approach a case with spherocytic anemia. Right. In a neonate, what are the causes of spherocytes? Suppose it's a newborn.
Hemolytic disease of the newborn.
Yes. There you will think of hemolytic disease of the newborn. Which one? RH or ABO incompatibility? Which one? It's more likely to show spherocytes. ABO incompatibility shows spherocytes. RH shows polychromasia, NRBCs, etc. Okay, so keep that in mind. Depending on what age, what history, your spherocytic anemia diagnosis will vary. All right.
Okay.
Any questions, or shall we move to the next? I have another, a part of case 2 that I'll show it to you. Okay, let's another case. Who will describe? Someone who hasn't spoken is here. Chaitra, are you there?
Yes, sir.
Yeah, go ahead. Okay, you've been speaking. Okay, fine. Fine, Chaitra, pick it up.
35-year-old lady unwell since 1 year. With history of arthritis, anemia, fever on and off, pallor, mild hydrous, and spleen is of size 2 centimeters.
Okay, so this again looks like a kind of a hemolytic anemia. Pallor, icterus, splenomegaly, refractory anemia, 35-year-old lady. So you get the smear. Just quickly describe to me the smear.
RBCs are sparsely distributed, and some spherocytes are seen with
spherocytes are
RBCs.
NRBCs quite a few, right?
And few polychromatophils.
And polychromatophils. Perfect. Polychromatophils and RBCs. So this is what you would get in a
Autoimmune.
Yeah, no, before that, this is what I mean. This is what you can safely call as evidence of hemolysis is going on. I can see hemolysis. Okay, not in the previous one. Previous one, the hemolysis was kind of subtle. So here, no one will prevent you from saying I'm seeing hemolysis in the smear. Fine, you can write it out safely with spherocytes. Okay, another such thing. Somewhere you notice something's happening. Some kind of an attempted activation. Yeah, here and there, 2 or 3 RBCs appears to be stuck together. Another one, nice polychromatophils, doublets are there. NRBCs, okay, fine. Lot of spherocytes. Another one. So what next? What do we do here next? Petra, or anyone? Okay, you could do a retic count. You could do a reticulocyte count and then move ahead and do your Coombs test. Fine. Retic count was 80%. LDH is another good marker for hemolysis. Elevated Coombs test is 4+. Fine. Next. What is the next test you will do?
The liver function test we can do.
I can't hear Shivani. Can you be louder?
Liver function test, sir.
Why would you be interested in liver function test at this point?
So if hemolysis is happening, there could be unconjugated bilirubin. So
yeah, I told that. Bilirubin is elevated. Liver function test. That evidence of hemolysis is there. Now, as far as my diagnosis is concerned, what more am I going to do in this particular case?
Incubation.
So we can
You
do
want to do osmotic fragility at this point? There is no need. Once you have a DCT positive spherocytes in the smear, there is no point in doing an osmotic fragility test or an incubation fragility test because anyway it's going to be shifted to the right. Yes, Megha, right. You will try and find out the cause for DCT, and DCT 4+ is always good to do whether it's polyclonal or monoclonal. So with your Coombs, IgG, IgM, complement, that's what is my next step. Okay, so that I can understand whether it's a warm type of hemolytic anemia or a cold hemolytic anemia. We'll come back to this case in the fourth case when we discuss it. So you do an ANA profile, you work up for the possible cause for hemolytic anemia. Is bone marrow indicated in such cases? Autoimmune hemolytic anemia, do we do a bone marrow?
No, sir.
Any possible indication of doing a bone marrow?
So if any underlying leukemia is there?
Leukemia, which type of leukemias?
Multiple myeloma.
CLPD. Suppose you find lymphocytic preponderance in the peripheral blood, elderly person.
CLL,
myeloma, those are possible causes of secondary autoimmune hemolytic anemia. Okay, so in such situations, yes, maybe a bone marrow is warranted, but not generally in a thing. Okay, or if you're planning at times, people say when one of the treatment modalities for AIHA is splenectomy. Before doing a splenectomy, you can do a check marrow just to see that the marrow is clear. And it just shows hypoplasia. So bone marrow is not indicated. Many times the clinicians kind of persist, no, let's do a bone marrow just in case. Such situations not necessary. But yes, if there is other cytopenias, patient also has a thrombocytopenia or a leukopenia, or you're seeing atypical cells, yes, go ahead and investigate. Not general. So this was an SLE induced autoimmune hemolytic anemia, right? So basically, causes of spherocytes are plenty. Hereditary spherocytosis, autoimmune hemolytic, HDN, transfusion reactions, intravenous water infusion, drowning, burns, DIC, RH null phenotype. These are all the causes. But as someone said, please check out whether you have transfused the patient, whether it's a recent transfusion, especially in childhood. Children, pediatric age group, the transfused RBCs can be seen quite prominently in the peripheral blood. Okay, shall we move on?
Yes.
Who will take up case 3?
Okay,
go ahead. So there's not much history provided, right? 18-year-old boy and hemoglobin of 6. Yeah, please describe. Who's doing it? Shomisha?
Yes, sir, I can take.
Yeah, one of you please.
Sir, the peripheral blood smear shows microcytic hypochromic cells, and there are target cells seen, and severe hypochromesia is seen, and a few sickle cells are also seen.
Okay, anything else you saw?
Target cells.
Target cells.
Sickle cells.
And
Yes, sir.
anything else? Fine.
Sickle cells.
Yeah.
Sir,
Anything else you've seen? Anyone in this particular slide? Element cells. No, let's avoid the word using element cells. Huh?
Schistocytes.
Histocytes. No, I wouldn't think of histocytes at all in this slide. What is this slide showing?
Sir,
Yeah, how many of you noticed it? This one?
sir,
There are two sets of lines.
Yeah, all of you noticed it now, or did you notice it when the slides were given to you?
When slide was given.
Yes, sir.
Some of you noticed. So that's a very, very important finding in the background of what you're seeing. So you must describe it as there's kind of, and I'm not very sure if I'll call this microhypo, normocytic, normochromic, plenty of target cells, sickle-shaped RBCs, along with prominent Hubble Jolly bodies. Okay, so that would be my whole overall impression or description. That would aid my impression. Another one, notice a Hubble Jolly in a target cell. Okay, so what's your thought?
Sir, sickle cell anemia.
Sickle cell anemia. Okay, sickle cell disease at this point of time. Right? Let's not label it as a sickle cell anemia straight. So what is your impression? Was that fine? Any specific history and examination that you would look for?
Spleen.
Yeah, you would like to look for the spleen. Very good. Whether the patient has had a spleen, does he have a spleen, or spleen is not there? What would you think with Hubble Jolly bodies present?
Post splenectomy.
Splenectomy.
Or auto.
He's still has no history of any surgery. He's not had a splenectomy.
All those
What was
spleen,
sir?
sir.
Spleen
It reflects hyposplenism. Okay, Hematology bodies, not necessary that they have to undergo a spleen has been removed. They represent hyposplenic state. Yes, you can also get Hematology bodies in a megaloblastic anemia. Sickle cell anemia patients may be folate deficient and megaloblastic, but not this slide. There were no features of megaloblastosis in the particular slide. So when you see Hematology bodies, keep that in mind. The patient's splenic function is going down. Okay, so that's important. So what further investigations?
Hemoglobin experience.
Okay, you can do a so this is the history that I can give you. 18-year-old boy. What would be his fine, sudden onset cramping, pain abdomen, chest pain, fever. He's been having swellings in his fingers since 3 years of age. Jaundice, spleen is not palpable. He's severely pale, and there is tenderness in the abdomen. So that was the clinical history with which he came. So any other information you want from the history? Something that will help you aid in your diagnosis.
Family history.
Family
Okay,
history.
family history. Anything else?
So acute abdomen syndrome and
That's there. Acute abdomen syndrome is there. History. We're not yet into radiology, not yet into
Sir, the
just from
ethnicity.
beautiful.
Ethnicity.
Where the child comes from. What is his ethnicity? That gives us an enough important amount of information, right?
Yes.
So the hemoglobin and all are there. You got a bilirubin which is indirect. Retic is 7%. So and MCV is around normocytic normochromic. So we don't have a very big hypochromic component to this normocytic normochromic. All right. So further pictures, sickle cell again, right? Hematology bodies. These are some of the other slides which I have not shared, but shows a very similar picture. Notice the target cells. So sickling test. What do you want to do in this?
Yes, sir.
Yes, sir.
You want to do? All of you say sickling test.
Yes.
To what purpose?
Check the sickling.
To what purpose would you want to do a sickling test? Why do we do a sickling test?
To know the percentage.
To know the percentage of sickle cells. Once you are seeing sickle cells in the peripheral blood, convincing sickle cells in the peripheral blood, I don't think sickling test is of any use. We do sickling test in traits. When we are not getting sickle cells in the peripheral blood, then yes, you would try to initiate sickling, the process of sickling, and go ahead and do it, right? There are these solubility tests by which we do these screening tests. Electrophoresis, if it's available, yes, and you get a slow moving band for sickle cell anemia. So that's the control, hemoglobin A, and that's the patient, which is slow moving. Mind you, in hemoglobin electrophoresis, the slow moving band migrates with hemoglobin D. So you may have a problem. Keep that in mind. And HPLC, right? Okay. So HPLC here shows S window of 72% and an F of 23%. A2 of 2.5. So what would you think of? S is 72, F is 23. A is about 2%, 1.9.
So it is a
Should
trait.
be sickle cell anemia or sickle cell
Trait,
thalassemia?
trait, sir.
Thailand sickle syndrome.
Huh?
Sickle cell trait.
Trait.
Trait. You're seeing sickle cells in the peripheral blood. It cannot be trait with a 72% of sickle cells. Sickle cell trait will have more of A. Here you've got a hemoglobin F.
So sickle cell
You
disease.
can see a lot of chats going on between homozygous sickle or sickle thal or sickle cell anemia.
Sickle cell.
Okay, we come back to this. Keep it in mind. It's important to do a parent screen. Why?
Osmosis.
Some of you felt if it's homozygous sickle, both your parents will be showing sickle cell traits, right? But some of you felt with HBF, are we dealing with a sickle thal? Some of you even thought of it as, yeah, very nice. Thal. If it is sickle thal, do a parent screening and rule out a beta thal and a sickle component. This, okay, so that's important. So how do you explain F of 23%? Anyone? Okay, let's see. We'll go into this. Are you aware of the basic defect in sickle cell disease?
Yes, sir.
You don't have to answer. You don't have to answer. If you are wanting to know what is the spectrum of sickle cell disease,
Sickle cell.
traits, homozygous sickle cell anemia,
Homozygous heterozygous.
Heterozygotes.
just
Trait anemia and disease.
disease, and also heterozygous. Sickle can combine with thalassemia, sickle can combine with hemoglobin E, sickle can combine with hemoglobin D, the heterozygous group. So that's also a part of your sickle cell disease. Yeah, perfect. Perfect. So these are all things that make the spectrum of sickle cell disease. Where is the sickle cell belt in the country? All aware of it?
Sickle in southern part of India.
Not really southern part. The states that where sickle cell disease is there.
Central part.
Madhya Pradesh.
Central
That is
part.
the central part. Madhya Pradesh, the central part. Okay, that's the sickle belt. There are some small sickle belts part in southern India, Tamil Nadu, and the Nilgiris, etc. Kerala, yes. But the major belt is Chhattisgarh and Orissa. Okay, keep that in mind. So that's how it is. The red one is sickle cell. Can you connect these terms? Benin, Cameroon, Bantu, Senegal, Arab, India. Anyone knows what I'm talking about? When we are dealing with sickle cell, these are called the haplotypes. As you know, sickle cell is very common in Central Africa. Okay, these are not the prevalent countries. Yes, they are prevalent countries. More important, there are also certain haplotypes of sickle based on which the clinical manifestation presents. Okay, so keep that in mind. Read it up. And Indian is the Arab India, where the fetal hemoglobin is on the higher side than in the other types of sickle cell. Now, why is it important? This fetal hemoglobin, what does it do, and how is it useful?
It prevents sickling, sir.
Yes, very good. Hemoglobin F prevents sickling. One of the treatment modalities of sickle cell anemia is hydroxyurea therapy, which increases hemoglobin F. And we are lucky, kind of lucky, in the Indian subcontinent, the fetal hemoglobin is slightly on the higher side. The haplotype of sickle cell in India accounts for a higher HbF. So you might get an HbF which is on the higher side, mimicking a sickle thal combination. Right? Yeah, Prasad, you are right, absolutely. Indian haplotype, please read to his chat. He's answering very well. Dr. Prasad, thank you very much. So they are milder versions. So sickling is not it's a milder version of sickle disease that happens in Indian population because of this haplotype. And that's why HbF is important. Okay. Can you link these three names? This is just trivia. Anyone knows anything about sickle cell disease? Walter Clement Noel was a dental student. He came from the country, a South American country called Granada, to study in the US and used to frequently fall ill. Ernest Irons was an intern who saw his blood smear and noticed that there were very peculiar cells. Walter Clement Noel at first approached the cardiologist James Herrick for his treatment, but James Herrick, being a cardiologist, was not interested. Until Ernest Irons, the intern who saw Clement's blood, showed him the sickle cells, and then he became very interested and published a paper. The first article on sickle cell anemia was published. We say that James Herrick discovered sickle cell anemia. The poor intern was nowhere in the picture, but the paper got published. Okay. The first case of sickle cell actually came from southern India. In Indian history, they were from the tribal population in Tamil Nadu, but sickle cell is more prevalent in the central part of the country. Okay. Case 4, who's taking up? Who's doing?
Also, it is raining. It is raining there in Guyana.
Okay, fine. Thank you. So the match is going to be washed out. Okay, fine. Case 4, yeah. Who will do it?
Yes, sir. Yes, sir.
Who's doing?
Yes,
Okay, okay, let's go ahead.
59-year-old male.
59-year male with a low hemoglobin, right? Okay. So what do you say?
Sir,
Ritesh, you answer.
yes, sir. RBC agglutinations.
RBC agglutination is seen. Perfect.
Yes.
Right? So 2 or 3
Yes,
slides shown to you. Right? Agglutinated.
Yes,
What are the
sir.
WBCs?
Neutrophils.
Yeah,
Neutrophils.
neutrophils. Now, why do you want to look at the WBCs when you're seeing an agglutinated sample? We just now discussed autoimmune hemolytic anemias can be a feature of CLL. So please pay attention to the differential count that you get. Okay. Ritesh, what would you do? Okay, I'm giving you some history. This was not provided.
Sir,
So,
59-year-old male presented with breathless 2 days and also noted pain and darkening of fingertips and 2 days.
yeah, what does that indicate?
Raynaud's phenomenon.
Okay, kind of a Raynaud's phenomenon of coagulation.
Yes,
Right, perfect. So on examination, he had pallor. He didn't have jaundice, by the way. No organomegaly, and basically there was bluish discoloration and central cyanosis. Okay.
Yes,
Some
sir.
more of the pictures.
There is the
Agglutination.
IBCs
Okay,
and
general
agglutination.
perfect.
Yes, sir.
What do you think of the platelets?
Increased.
Increased.
Okay, adequate.
Increase.
Fine. Platelets are in good number. Perfect. High bar. Anything else you can notice? What are these RBCs?
Polychromatosis.
Polychromatosis. Yes, polychromatosis that are there. Right, perfect. So what will you do next, Vijesh? You are at your emergency night time. You are looking at the smear. What would you do, Vijesh?
Direct context.
Straight away you will order a direct test. Okay, fine. You don't have the facilities there.
So we can ask for incubation.
Or
Warm the samples.
Warm the
Incubation of
sample, right?
the
You don't need to ask. You are going to have put the blood sample in incubator 37 degrees.
37
and
degrees.
resmear, right? So that's what we did, and that's the resmear. So the agglutination goes off. As you know, that is basically it's a cold medium.
Cold
Cold
medium.
temperatures, agglutination. The tendency to agglutinate disappears. So it's a simple way to convince yourself. Yes, I was looking at the agglutination. Anything else, Vijesh? Simultaneously, you will do. Or Rick? You're sitting in the lab. The sample has come to you. What would you like to do?
So we can do rule of 3 also, looking at the CBC indices.
There's no rule formation in this, right? So why unless would you want to look at the sample?
Yes, sir. So
Yes,
Yeah, simple. Look at the sample. You can see the agglutinations. You can see the clotted. It's not really a clot. It's agglutinations that are forming. Right? Does the CBC help you?
CBC is
Yes.
3, I said.
Okay, look at the CBC of this patient, this particular patient. RBC is 0.32, markedly reduced RBCs. Hemoglobin is 8, hematocrit is 3.2. So what do you notice from here? The rule of 3 getting flouted. There's no rule of 3. And also look at the MCV, MCH, and MCHC. They are weird, really bizarre, and you know that this is not possible. Okay, so this is the typical CBC profile of a patient with autoimmune hemolytic anemia with agglutination. Okay,
Yes, sir.
once you have incubated, you rerun and the things become more or less normal.
Normal.
So your diagnosis is
Cold
Cold
agglutination.
agglutination.
perfect. Autoimmune hemolytic anemia, cold type, IgM related, right?
IgM.
So again, we not go into the theoretical part. You are supposed to be aware. You must know some things about it. So what are the causes?
infectious causes pneumonia,
Pneumonia. Which pneumonia usually causes?
mycoplasma.
Very good. Mycoplasma pneumonia is known to cause, right? Any other?
So drugs.
Drug-induced
Drug-induced is usually not agglutinating. Drug-induced hemolytic anemia is a different entity altogether. Any other condition where you get agglutination? Again, you are not disorder. Myelomas.
Myelomas.
And these are basically IgM antibodies directed against the I antigen. Hemolysis also occurs in the liver in these patients because complement is affected in this type of autoimmune hemolytic anemia, the cold agglutinin type. In the warm, it is mainly in the spleen.
The spleen.
Yeah, causes, as I said, it's again white. Monoclonal CLPD myelomas, polyclonal mycoplasma, and a whole lot of viral infections, liver transplant, certain connective tissue disorders, in malaria, DPT vaccination, COVID, and its vaccination. Both have resulted in slight increase in cold agglutinin disease. Right. So soft pointers when you're looking at cold agglutination, agglutination, these are the things. Cross, look at the sample, look at the abnormal indices, warm the sample, and look for atypical cells. Right. Any queries at this point? Shall we move? So these are certain points that you must be aware of as a pathologist in possible questions that can come when you're dealing with a case of agglutination or autoimmune hemolytic anemia. Some words about management you must be aware of. Okay, as a spotter, what does this show? It's like Roulet formation. Yeah, so this is Roulet formation. So differentiated from agglutination, this is Roulet formation. You see the RBCs in stacks. There is no clumping. Okay, there's no specific clumping. And you notice what are these cells?
Plasma cells.
Plasma cytoid cells. Good, plasma cells. So you are when you see Roulet formation, check it out. Okay, Roulet formation, plasma cells. So you're possibly dealing with a plasma cell disease. So learn to differentiate agglutination from Roulet formation. What would you do when you see too much of Roulet formation? How would you improve your smear?
Fresh sample.
Fresh smear will again show Roulet formation, right? The patient inherently has lots of immunoglobulins, so that's why the rouleing is ugly. When you see agglutination, you warm the smear sample. What will you do here?
It's simple.
The slide should be.
You will dilute the sample with a normal slide. Okay. Once you dilute, the RBCs tend to, the rouleing tends to decrease. So you repeat the smear after dilution. The rouleing will go away. Okay. So again, the questions that can come when you get a slide with rouleing is why there is rouleing formation. You should be aware of. What are the conditions where you see rouleing formation? Know about DSR, significance of plasma cells in circulation. Okay, percentage of plasma cells in circulation, so that you know whether it's a plasma cell leukemia or just a myeloma with a little spill of plasma cells. Okay, it's important. So these are the possible areas where questions may be asked. Okay. Again, a little puzzle or a trivia question. One question. My full name is Robert Royston Amos. I'm a veterinary surgeon, and these are my 3 important papers. Who am I? One paper was detection of weak and incomplete Rh agglutinins. The second 2 papers are on immunology and hypersensitivity reactions. Very good. That's Coombs. Okay, we know Coombs. I hope you remember your gel Coombs classification of the entire hypersensitivity classification that we have: type 1, type 2, type 3, type 4, and now type 5. He's the pioneer, and he's a non-medical. He was basically a veterinary surgeon, but he's a fellow of the Royal College of Physicians. All right, that's Robert Coombs. Okay, case 5. Who's describing? Varsha, are you there?
I'll describe, sir.
Okay, Gitanjali, fine.
Yes,
Who's describing? I can't really place you.
sir, Gitanjali.
So, who? Gitanjali, okay, go ahead. Start. Don't waste time. Right, go ahead.
Right.
Yeah.
Can't see. Yeah, sir, this smear shows normocytic, normochronic with a few hypochromic microcytic cell RBCs with fragmented RBC and schistocytes. The
Schistocytes, okay.
platelets are
So,
normal.
normal, okay. Now, can you describe it? Is it predominant? You said the word normocytic, normochromic with a few microcytic, hypochromic. Let's not sit on the fence all the time. It doesn't happen that way. Okay, so normocytic, normochromic. What do you mean by few microcytic, hypochromic? It's like sitting on the fence. Okay, maybe if they're there, the examiner will allow it. No. Okay, so be confident about what is the most significant finding. All right, all of you. Don't say everything for everything. Okay. All right, so this is schistocytes, right?
Yes, sir.
Fragmented RBC, helmet-shaped RBC. So,
Helmets.
and that's an important. Okay, schistocytes, right?
Yes, sir.
So, what are your thoughts?
Sir, I'll ask for the history
Very good. What will you ask in this?
for
Just
like
one or two
any
statements, renal impairment. Good.
renal disease,
LDH,
Yes.
CM LDH.
RD,
Right.
for pregnancy,
Pregnancy,
for
fine,
DIC.
fine. So this patient was basically,
Overactive
your history is there. 26-year-old lady, primary gravida, 37 weeks, seizure and bleeding PD one day. LSC has done, pallor, but she did not recover. She bled to death practically. Okay. So that is the history of this patient. So investigations were done, and this is what we got. Baseline, normocytic on the higher side, not really macrocytic, platelets low, and retic 7%. Okay. So what will you do next?
Sir, liver profile.
Okay.
And
There you
DIC. So, it is raised.
bilirubin is elevated. Mixed type, urea creatinine elevated. PT and APDT, PT borderline increased, APDT elevated. Okay, so that's what we are doing. So we are moving towards a diagnosis of.
Health syndrome.
Okay, broad classification, broad entity.
DIC.
Microangiopathic hemolytic anemia. This is all this entire group comes under microangiopathic hemolytic anemia. Okay, so basically red cell fragmentation, secondary to endothelial damage, and capillary fibrin disturbance. And there are multiple causes for this. Okay, why? Just give us one or two important causes.
HUS.
HUS is a pediatric emergency, mind you. Diagnosing microangiopathic hemolytic anemia is an emergency. It's a life or death matter. So TTP, HUS, DIC. Okay, these three important, but there are many causes where RBCs fragment. Okay, venom-induced coagulopathy, sepsis, liver disorders, pregnancy-induced
Even burns,
hypertension, Hill syndrome, disseminated malignancies. Yes.
Burns.
Prosthetic
Burns and sepsis. Yes.
Prosthetic
Mechanical. So in this setting, it's very important that you identify schistocytes. Okay, you identify schistocytes. Okay, it is one of the very critical findings that one needs to appreciate and be able to diagnose. So do a blood film, and the blood film shows schistocytes. Okay, with frequent polychromatic cells. So this combination of schistocyte being the most predominant poikilocyte, along with thrombocytopenia, this is a clue to the diagnosis of MAHA. Okay, you normally would not expect too many other types of RBCs if it's a true case of microangiopathic hemolytic anemia. So predominant finding is schistocytes. And how many schistocytes are important? How do you grade schistocytes? Okay, this is another thing that's important. Yeah, we'll just talk about that. You can identify schistocytes looking at the RBC histogram. These fragmented RBCs all shift to the right. You don't have a lower discriminator. They may mix up with platelet count. At times, be careful. Your platelet counts may falsely come elevated because the fragmented RBCs get counted as platelets. So that's why when you do an optical platelet counting, it's better. But in impedance type of platelet counting, you can land up with such cell counter pseudothrombocytosis occurs here. So that's the typical platelet curve that you get in DIC or microangiopathic hemolytic anemia. And that's the RBC. There's a bulge or a shift towards the platelets, and this is a typical smear of DIC. It's a finding of ominous significance. Okay, this is important. I want all of you to pay careful attention in all such cases. You grade it. Okay, but again, you're giving this to count as which is grading even 1% plus is important. And so be very careful when you are labeling schistocytes. Don't label a case of thalassemia showing schistocytes, case of phagocytosis showing schistocytes, case of G6PD. Schistocyte is a very specific terminology where you're meaning the red cells are getting fragmented. So along with thrombocytopenia and RBC, when the main morphology is schistocytes, it's diagnostic. And this is something that you need to diagnose when you are sitting in your emergency or wherever, because it's a critical finding. So it has got lots of causes. So when you get a clinical and a smear suggestive of MAHA, how would you approach? Next. Get the history, do a renal function test. You may want to do a paracoagulation test if you there, but know that there's something called a DIC score. DIC score. If it is TTP, you'll think of plasmapheresis. If it is TTP, what is the diagnosis? What tests help you in diagnosing TTP? Currently, not many places have it, but have you heard of Adam PS13? Yeah, Adam PS13 levels less than 10% is indicative. So there's something called a DIC score: platelets, D-dimer, PT, and fibrinogen. Okay, keep this in mind. There's something for TTP called a plasmic score. Platelet count, INR, there's PT INR, creatinine, hemolytic score, whether it's retic or haptoglobin or increased bilirubin, MCB, and a history of cancer or transplant. So that's another clue for TTP. Mind you, when you diagnose TTP, don't transfuse platelets. It's probably not a right thing to transfuse platelets, even if the platelets are low. And Adam PS13 levels. So this is how I would approach a patient with schistocytes. This is the DIC score. Please go through it. Over DIC is when the score is 5. This just tells you that this particular patient is possibly going into DIC. Okay, and that's how we report on it. Similarly, remember just a few words on TTP acquired causes. Various types, immune-mediated or secondary to massive endothelial stimulation. So both of these are causes of TTP. So that is an important diagnosis to make. So you must be aware of. And TTP, etc., will come often as your theory paper also. This is one commonly asked question of approaching TTP. Okay, just a prelude or another very similar. I think someone in the chat was asking. Just tell us, this is a 20-year man with a hemoglobin of 4.2. What do you see here? These are? So can you think they are fragmented? Anyone else?
Helmet cells.
These are helmet cells. These are white cells. Okay, they are the part of the RBC is actually destroyed.
Bites.
Yeah, and what are these? What are these?
Ghost cells.
These are blister cells. So
Yes,
white cells and blister cells often mimic schistocytes. Okay, so keep that in mind. Try and differentiate. See as many cases as you can. Look at the pictures. They often are similar looking, but they can be different. So this is again an oil immersion blister cells. So what would you do next when you get a white cell? You'll do a retic count. And how do you diagnose white cells? What test do we do?
Retic.
Retic is here. Anything else? Supravital stain. Right? You can do a methyl violet and look for what are called Heinz bodies. Basically precipitated, degraded hemoglobin form Heinz bodies, and this is what causes the bite. These Heinz bodies are not stained by Romanowski stain. Earlier, we used to think that pitting and repeated pitting and culling causes these white cells. No, the white cell that we see or the blister cell that we see is basically the Heinz bodies or the degraded hemoglobin, which are not stained by the Romanowski stain. And that's why you get a little yellow or a little pallor. Many causes, commonest is D6PD deficiency. Drugs, many drugs are there. Chronic liver disease, Wilson's disease, another cause. Post-splenectomy, you might get certain poikilocytes which might resemble a white cell. Keep that in mind. So that's a white cell, also known as a degmocyte. That's a schistocyte or a fragmented cell. So keep that in mind. Okay. That's the prevalence of D6PD deficiency worldwide. Another question for you, little fun quiz. That's D6PD. What do you think this is the prevalence of this disease?
Malaria.
Right, malaria. They parallel. I hope you're aware of the fact why D6PD deficiency and malaria parallel each other, and why is it that they're kind of endemic in the same reason? Again, if you don't know, find out the answer. What about this? What does this slide show?
Sir,
Salient features?
hypochromesia.
Okay, to some extent, right?
Acanthocytes.
Sites are seen.
Acanthocytes, very good.
Acanthocytes.
And what is this?
Halo jolly body.
Heinz
Jolly
body.
body. So what do you think this patient has?
Chronic liver disease.
Renal disease.
Chronic liver
Why Halo jolly bodies? Any other thoughts? Yeah, find Dr. Sanjeev Kumar, NRBC's acanthocytes, Halo jolly bodies. Target cells. So what's your thought? Yeah, Shomishta, anyone? Asthenia. Okay, so what questions do you ask?
History of thalassemia.
Sickle.
History of splenectomy. This is the post-splenectomy smear. Classical, when you get this combination, post-splenectomy smear, you can get Howell jolly bodies individually in megaloblastic anemia. You can get target cells and liver disease, but this conglomerate finding of Howell jolly bodies, acanthocytes, target cells, usually with thrombocytosis, etc., is indicative of post-splenectomy. So that's important. Okay. So when you are ruling, this is how it is. Please report if it is present, Howell jolly bodies. Many feature. It's also useful to look for Howell jolly bodies in patients of ITP or autoimmune hemolytic anemia who have undergone splenectomy. When they come for follow-up post-splenectomy, please look for Howell jolly bodies. Absence of Howell jolly bodies indicate that probably your splenectomy was not enough. There may be some splenunculi, accessory spleens that are left behind. So that is an important finding to look at. Okay, when you're following up patients of post-splenectomy. Right, good. So now let's finish up with the RBCs. Quickly move on to the WBCs. These are more easier, I think, cases, straightforward. So we have this. Who's going to describe now? Okay, go ahead.
So this is a 14-year-old schoolgirl presenting with complaint of severe fatigue of recent onset, and for last 3 months she has been having menorrhagia. The hemoglobin is reduced with normal WBC count, and platelet count is reduced with thrombocytopenia.
Okay, the slides.
So here the RBCs appear as normocytic normochromic cells with very few schistocytes.
Good, there are schistocytes. Good that you identified them.
So
Right.
WBC here it appears as an abnormal promyelocyte with a bilobed nucleus on the
Fine. All of you picked it up well.
with the right one showing few convoluted nucleus, and the cytoplasm is agranular to sparsely granular basophilic stand.
Okay, here, but notice the cytoplasm lower down looks kind of very granular, kind of pinkish. Okay, so what's your diagnosis that you thought of?
So this is a case of acute leukemia of myeloid origin and suggestive of APML, acute promyelocytic.
That's how you would good. That's how you would report it off as acute myeloid leukemia, myeloid in origin in favor of acute promyelocytic leukemia. With if there are schistocytes, say presence of BIC or microangiopathic hemolytic.
Yes.
All right. This is again like your schistocytes in the WBC counterpart. Again, an emergency diagnosis. You must all learn to appreciate atypical promyelocytes or neoplastic promyelocytes because APML has a specific treatment which, given early, you can cure the patient. So this is important. Okay, so just to have a look at different types of morphology. Mind you, this is which type of APML?
Microgranular.
Okay, so
Microgranular.
for some reason we are finding the number of cases of APML hypogranular variant is kind of increasing. The classic APML is there, but of late we have been seeing too many of these hypogranular variants. I don't know why. Okay, so some of the pictures that show the morphology of hypogranular. So you would report it off like this: few points, blast plus atypical promyelocytes. Neutrophils are generally absent in promyelocytic leukemia. That's another clue. You won't get maturation, right? So this is how it is. So what next?
Sir, next we go for if you want to confirm
You have to, not if we want to. You have to confirm.
So
What you do?
cytoplasm.
Yeah, preferably you can do a myeloperoxidase if you have to change a black or something. And this kind of a firework is called kind of a blush. Even the hypogranular variant are strongly positive for MPO. It's as if the granules are moving out of the cell. That's typical MPO that we get. But yes, you have to do a flow cytometry. Typically, normal, the blasts are usually in the CD45 region. MPO positive with negativity for 34 and HLA. That's the standard. And further in this particular patient, of course, cytogenetics was done. Bone marrow was positive. The biopsy had this typical appearance, very granular and kind of separate from each other. Some people call it plasmacytoid. I think it looks more like a fried egg appearance. Each cell is kind of separated because the granules are there that come out and the cells kind of retract. So it paves way for your both cytogenetics and fish. What translocation?
Sir, PML RARA
17 is the cytogenetic translocation and PML RARA. Okay, so keep that in mind. So again, this is the morphology. There are two types, hypergranular, micro or hypogranular, and there are certain variants which are also present, which may not look very typical of APML. Classical packet cells, a stick, bunch of sticks, a bundle of sticks. The old English word for bundle of sticks was packet. And the hypogranular variant is about 25% in literature, we are finding it. And this is the cottage loaf appearance of, again, a trivia of the nucleus. Figure of 8, buttock shape, all kinds of names we have given. Then this is the cottage loaf appearance of APML hypogranular variant. Okay, so these are the two things. This is again something that you must remember. It's a medical emergency. Okay, it's a critical diagnosis. The part of your critical reporting is APML. Often the classical form presents with pancytopenia, so it may be difficult to pick up the cells, but you can pick them up. Also look for features of DIC, and this is very, very important. Call your resident; they can start treatment while the report is pending. ATRA will not really kill the patient, so you need to be very active when you are looking at promyelocytes in your slides. Okay, some more pictures of acute leukemias. What does this show? These are all rods. Okay, so these are myeloblasts with all rods. I hope you are able to, you can pick up. Morphology is often good, though you need immunophenotyping and cytogenetics. Morphologically, you can pick up. What about this? What does this cell show? Overall, what is the morphology telling you? These are monoblastic, grayish cytoplasm, abundant gray cytoplasm, reniform nucleus. Okay, so much so that hypogranular M3 can often be mistaken for monoblastic leukemias. They have that very similar kind of a very lacy nucleus. It's called a lacy nucleus, abundant gray agranular to mildly granular cytoplasm. So this is typically a look at a monoblastic. But this also has odd rod, so it could be a myelomono. Odd rod, again monoblasts. What is this?
So
What does this show?
this
Dominant.
Cup-shaped nucleus, cup-shaped nucleolus or cup-shaped. So what does that tell you?
With NPM1 mutations.
Yeah, the molecular NPM1 mutations. Now these are slides that may come to you in your exam. So morphologically, you will call this an acute leukemia. Better not even say it's myeloid or lymphoid, but these are morphological clues that will tell you. So when you're reporting it out in an exam, no one will tell you, okay, even with let's say 90% blasts, if you're non-specific, it's fine. But we would expect you to pick up this finding. In your description, please write down that these are cup-shaped and so possibly it's an AML with an NPM1 mutation. So that is how we would expect you to describe this slide. What about this? You get a smear which shows this picture. Okay, blasts are there, right? What are these?
Lymphoids.
What are these two cells? They are basophils, right? They are basophils. Most of these are normal basophils. So you get a smear where there are blasts, not sure lympho or myelo, but you also see a lot of basophils. What's your thought?
CML.
CML with blastocysts. Okay, CML blastocysts. So this could be another slide that could come to you. CML with increase in the blasts. Okay, so basophilia, thrombocytosis in such cases, you would think of. Okay, this one.
The lymphoblasts.
They look lymphoblasts, but again, morphology can be so. Here, if you say 90% blast, acute leukemia, morphologically resembling lymphoblast, you're fine. Don't be categorical and say this is ALL, L1 or L2 or L3. No. Okay, right now you know that with immunophenotyping, the morphology often is not very specific. So here we would expect you to identify them as blasts. Yes, they are blasts, they are not reactive cells, they are not normal cells. But you can always confidently say, I really cannot tell whether it's myeloid or lymphoid. No one is going to penalize you. Okay, so be bold when you are answering questions. What about this?
Blasts.
NPM hand mirror cells.
Hand mirror cells. Okay, so some morphology. So possibly lymphoid again, but we would appreciate if you pick up these hand mirror morphology. Okay, this one. Vijesh?
Monoblast populations.
Dominant vacuoles with a deep blue cytoplasm.
Lymphoblasts, sir.
Which type of lymphoblast?
3.
Once upon a time, you would call it as ALL-L3. Currently, please don't use the word ALL-L3. Say that resemble ALL-L3, they're possibly Burkitt leukemia. Okay, Burkitt cells. Okay, Burkitt lymphoma. So some of these blasts may have some morphological peculiarity, which you will be able to identify. Okay, right. Okay, let's move on. Case 7. Who will do it? Hand mirror cells, okay, Dr. Sanjeev Kumar is a type of ALL, which has this morphology. It's just that. Hand mirror cell leukemias are basically acute lymphoblastic leukemias. Yeah, who will do it? Next one. Case 7.
Sir, I will do RBC series, sir.
Yeah.
Yes, sir. It's a 10-year-old boy.
Yeah.
Here we can see the RBC series shows microcytic hypochromic cells, and the RBCs are reduced in number. The WBC series shows cells which have high NC ratio, dense chromatin, nuclear chromatin, and also we can see some bizarre platelets, and also the WBCs have the cytoplasmic projections or blabbing. We can see. So this most probably a case of yes. Here also we can see cytoplasmic blabbing, and also
there are two blasts provided. What does this look like?
Yes.
What does this look like?
This is looking like a myeloblast.
Right, this looks like a conventional myeloblast, right? All of you from the nucleolus, slightly vesicular schematic. But this one is more dark, and you have these blebs. What does this tell you?
Sir, it's a bizarre platelets or
Bizarre giant platelets. So what is your thought? I'll show you some more slides. Yeah.
So it is most probably it's a case of acute leukemia, most probably AML M7, sir.
Very good. So don't say AML M7 straight away. They are megakaryoblast in morphology. Appear possibly megakaryoblast. Okay. Good. So appreciating the heterogeneity of the blasts, different sizes of the blast, different shapes of the blast, and the blebbing is important. Okay, now this case you've not seen. I'm showing you the bone marrow, was a cellular marrow, and again there were these some obvious myeloblasts, but notice the bizarreness. Notice the pleomorphism amongst the blasts, right? With a lot of NRBCs. These were some of the blasts. Anyway, this is just to complete the case. CD34 was positive and CD61. CD61 is a megakaryocyte marker. 34 is a myeloid marker. So the biopsy also was very cellular with abnormal megakaryocytes. Some of them are blastic, mononuclear. Some of them are very dyspoetic. What stain is this? Reticulin is increased, trichrome, which showed collagenization, right? 34 was positive, 61 was strongly positive. So this child, this 10-year-old child with the karyotyping, and that turned out to be a Philadelphia chromosome. So it was basically a childhood CML who presented as blast crisis, and that too megakaryoblast crisis. Okay, so when looking at blasts, look at the morphology. Odd rods will be there. APML is typical. Monocytoid blasts have a different appearance. Lymphoblasts have a different appearance. Hand mirror appearance, blebbing. Okay, these are some of the features that give you a clue to what the leukemia could be. Look at the other myeloid cells also. Is there maturation or are they totally absent? In M3, APML, you don't see maturation at all. Look for eosinophils. You know there's an entity of M4 with eosinophilia. Look at the basophils. There are acute myeloid leukemia with basophilia, acute basophilic leukemia, CML with blast crisis. So your peripheral blood gives you a lot of clues to the final diagnosis. No one can say for sure what your leukemia is looking at the peripheral blood, but you can get a direction to where you look at. Look at this myelopoiesis. Are you seeing pelvic cells? Are you seeing very dyspoetic neutrophils? Possibly it's a MDS which is going on into a blast crisis. Okay. Look at the RBCs, look for schistocytes and look for platelets. Okay, so that's a general algorithm that we follow. Right? Any questions? Okay. What am I talking about? Another trivia. Thomas Macrae first described them as acute lymphatic leukemia with a report of 5 cases in 1905. One paper came out by Thomas Macrae. Subsequently, next year, this gentleman, whose name I have blocked out, described hitherto undescribed structures in the large lymphocytes in the case of acute leukemia. What am I talking about? What do you think this person's name is? John Auer. Actually, John Auer described what Macrae had already described. In fact, in his article, he said this is actually the 4th case of the series of 5 cases that Macrae. But for some unknown reason, it is known as Auer rod. There is a current talk whether to change the name Auer rod and turn it into a Macrae rod. But that's trivia. Okay. And notice both of them had reported Auer rods and what they thought was acute lymphoblastic leukemia. Now, so much has changed over the years, so much we have learned. But this is the origin of Auer rod. Actually, it's pronounced as Auer rod. It's not Auer. Okay, case 8. Who's describing? Hello? Who wants to do this?
I can do.
Ankita, are you there?
Shivani is doing it. Shivani.
Shivani, okay, come along.
It's a 5-year-old male partial dyspnea since 6 months, HB 4 grams, but estimated TLC is 3100, platelet 11,000, and MCV is 115 from 22.
Okay, so what do you understand from this?
So pancytopenia, HB is also less, TLC is
Right,
also less.
pancytopenia with
So
macrocytosis, right?
macrocytic.
Possible macrocytosis. Okay. Yeah, tell us what you saw.
Sir, in this RBC and isopoikilocytosis with macrocytes, few elliptical cells, teardrop cells are also there. So I found 2 schistocytes also in this.
Okay.
And
Again,
hypertonia
be careful about schistocytes in this setting. Okay, they may just be irregular poikilocytes. What is this?
So NRBC 1 and NRBC
What
also.
is this?
So this is the neutrophil showing dysplasia dysplasia with the phalguroid.
Very good. Phalguroid or phalguroid kind of a neutrophil, right? And this one?
So this is the the high
Okay. And low power, fine. But you find this is atypical. Looks atypical, right?
Yes.
So fine, perfect. Macrocytic, teardropping, NRBCs, phalguroid neutrophils, and a blast.
So
Again,
again,
monolobe, yeah, right?
yes, sir. Hypolobate forms are there,
Hypolobate.
2 lobes are there. Yes, sir. And again, phalguroid shaped neutrophil is there.
Slightly
Sir,
hyper.
Sir, instead, it appears to be cell with a high NC ratio, but chromatin is a mature chromatin.
Okay, fine. But where would you place it? A large
So
lymphocyte or a blast?
So large lymphocyte.
You still want to call it a large lymphocyte. Okay, fine. Anyone else wants to differ?
Last.
How many of you? Blast. Okay, you thought of a blast. Okay, so we have a difference, fine. That's understandable. Okay, some more slides. Same thing, right? A normal
Yes, sir.
neutrophil
Okay,
and
the
a
one
phalguroid cell.
Yes,
What does this tell you? When you find normal neutrophils,
So
anyone?
just like
This is
So,
possibly
everything
dysplasia. It's possibly not a true Pellger-Rouet anomaly. Right? Pellger-Rouet anomaly can be a part of, one is a familial disorder. Okay, it's not true. We'll come to that. Okay, so that's important when you notice. Again, any idea what this cell is called? That's a Pellger-Rouet-like cell. Fine. What is this cell called?
Pseudocomplement cell.
A mononuclear
Pseudocomplement
Pellger-Rouet cell.
Pseudocomplement.
It has a tough way to pronounce. It's called a Stordmeister cell. I'll just discuss that in a while. Okay, so this slide is showing kind of hypolobe neutrophils, hypogranular neutrophils. The granules are also there. The size of the cells is slightly small. Okay, so these are all Pellger-Rouet-like cells. Another one. Now, what do you think of this, Johnny?
So this could be blast. Sir.
This could be blast. Okay, I'll show you more.
Yes, sir.
These are blast. So,
Conspicuously,
what's the diagnosis now?
Sir,
Yes.
MDS myelodysplastic syndrome.
I will consider this to be a peripheral smear and a possible myelodysplastic syndrome. Fine, very good. Okay, so just to show you what some more of our Pellger-Rouet-like cells, and this was the differential that we got. N was 34, majority were Pellger-Rouet-like, but there were normal also. L50 blasts were 14% in the smear, and the platelets were on the lower side. Right. So what next would you do?
So bone marrow.
You would do a bone marrow. Bone marrow showed 25% blasts. Cytogenetics was done. Again, that's important. And so monozobi 7. So along with Pellger-Rouet cells, look for other features of myelodysplasia: hypogranularity, abnormal lobes, ring neutrophils. Right. So these are the various on the peripheral blood. This is one article that has been published from one single case. This is in blood, the various neutrophils. Okay. This was another case which came to us very similar time. It was a 66-year-old lady who had a routine blood test for ovarian cancer prior to ovarian cancer treatment, and that showed hemoglobin of 11, TLC 25,000, platelets were normal, and this was her findings. Anyone?
So this is also hypolobation and
Yeah, but here notice that all the neutrophils are hypolobated. You don't see blasts, you don't see other forms of dysplasia, you don't see normal neutrophils. Okay, so this is what is called a Pellger-Rouet anomaly. Now these are the various morphology that you can see. It's called the spectacle shape or the princess shape cells. Some of them resemble a groundnut, and the mononuclear ones are called Stordmeister cells. So Pellger-Rouet morphology can be either a congenital disorder, where there is a mutation in the laminin receptor, or lactoferrin deficiency, uncommon, or it could be a part of myelodysplasia or AML. Okay, certain drugs are known to cause Pellger-Rouet-like changes. So keep that in mind. Certain infections cause this kind of dysbiotic changes. So one of the more common mimics, you need to differentiate a Pellger-Rouet cell from left shift. That's another one. Some of you came out with a diagnosis of toxic change and left shift. Yes, the Pellger-Rouet cells, you have to differentiate them from the band forms or metamyelocytes. That's important. Or differentiate the true Pellger-Rouet from the pseudo-Pellger-Rouet cells or Pellgeroid cells. There's some kind of a classification also of Pellger-Rouet cells. If you're aware of it, Hamsky, that's not very important. Fine. So now tell me, which one is Pellger-Rouet, which one is normal? Which one is left shift? This is left shift. This is Pellger-Rouet, right? That's a band form because it is associated with the neutrophil, right? This one? What's this?
Yes, sir. Yes, sir.
What is this?
So this is
A myelocyte.
myelocyte.
Myelocyte, what is the toxic change? Okay, so that's a Stordmeister cell and that's a myelocyte. Which is Pellger, which is a shift. Pellger, metamyelocytes, right? So keep that in mind. So when you see Pellger-Rouet cells along with this process, teardropping and all, this is possibly a case of pseudo-Pellger-Rouet or blast. So they are not true Pellger-Rouet cells. Okay, what you get as a feature of dysplasia. We call it Pellger-Rouet-like anomaly. Okay, the ninth case.
60-year-old male. So slide. So the
Go ahead.
smear shows microcytic hypochromic cells along with predominantly microcytic cells and many leucoblasts.
Just talk about the total leukocyte count. Let's not jump to the next cause of lymphoblasts. Total leukocyte count is leukocytosis, right? Let's describe it as leukocytosis, normocytic, normochromic, and you calling them lymphoblasts. All of them? All of you agree on that?
No, sir. Small
No,
mature.
sir. Mature.
Yeah, more mature or theoretic process, right? So I would put, what would your thoughts be on this?
Chronic
Rick,
lymphocytic
CLL.
Rick, what are your thoughts?
Sir, CLL can be.
Mature
Okay,
CLL.
so
Mature
let's look at them more.
Mature looking cells.
Mature
Soccer
leukocytes.
bone
Can you notice the nucleus?
Soccer bone chromatin.
Soccer ball, and what is this?
Sir.
It has a prominent nucleus, larger cells,
Prominent
because of
nucleus,
the
larger
a prolymphocyte. And Ankita, you would call them as microcytic hypochromic. Look at it on oil immersion, they're all normocytic, normochromic. So keep that in mind when you describe Microhypo, it's always at oil immersion that it's good to describe them. See them carefully and then describe. So basically, it was a gentleman with a 60-year man with generalized lymphadenopathy. TLC was 45,000, platelets were almost normal. Some more smear, what does this show?
Smart cells.
Smart cells.
Smart cells. Smart cells.
So this was our differential. 85% lymphoid cells, pro-lympho 6, the rest were neutrophils and eosinophils. Right. What next? It is again nicely shown the soccer ball type of the clump.
Soccer ball appearance.
It's got a uniform chromatin that you see and no nucleolus. Right. So I would report this off as CLPD. Please don't straight away call it CLL. Better to report it off as a CLPD, morphologically favoring CLL, and I would advise an immunophenotype. So what would you expect in immunophenotype?
CD20, CD19,
What happens to CD20 in CLL? Is it positive?
Positive.
How many of you say positive CD20 in CLL? CD20 is often dim, weak positivity, and that's the picture.
CD19, sir.
19 is positive.
19 is positive, sir.
19 is positive. 20 is dim or weak positive. 5 positive. 23 positive. Right. So that's keep that in mind. And that's 200 and others you can do. But basically, we rely on 19, 5,
19.
and 20 is weak. In fact, that's the strong point. If your 20 is weak, it goes more in favor of CLL. Generally, yeah, another point, whenever you're looking at a CLL, you must try and identify pro-lymphocytes. So the entity of CLL, PLL, not gone. Generally, CLL shows a sizable amount, less than 10%, are pro-lymphocytes. And how you diagnose pro-lymphocytes is they're larger, dominant nucleolus, eccentric usually, with more abundant cytoplasm. So generally, CLL shows pro-lymphocytes, the other ones don't. So again, what you need to know, you must know the criteria to diagnose CLL. Immunophenotype of CLL. I hope you're aware of the Matthews score.
Yes.
What all to report on the PS? In the PS, what else will you look for in a CLL?
So
One is
smart
the
cells.
pro-lymphocytes, smart cells, yes. And anything in the RBCs?
Spherocytes.
Spherocytes, because CLL is often associated with autoimmune hemolytic anemia. Do you need to do a bone marrow in CLL?
No, sir. No.
Not really. If you have a bone
Not
marrow,
really.
you need not, but if you do it, it's good to do a biopsy because a diffuse infiltration has a prognostic significance. A nodular infiltration, often if it's a stage 1 or a stage 8 CLL, a nodular infiltrate, you may even wait and watch. If the patient doesn't have lymphadenopathy, the counts are not high. So if at all you do a defined biopsy. I hope you're aware of the staging of CLL, various transformations in CLL, and what do we understand by monoclonal B lymphocytosis. So these are the possible questions that will come when you encounter a case of CLL. Okay, certain mimics. What is this? Again, one of our cases that we got. So what do you think when there is this kind of drastic cleavage through and through? What's your thought, Rick? The nucleus, mind you, is extremely hyperchromatic, like a mature lymphoid cell. So this is the DD of CLPD. Okay. This is what you get in follicular lymphomas. The typical once upon a time called buttock cells. That's usually a NHL, low grade NHL, like a follicular lymphoma. Okay, that's a feature of that. What about this? What about this? Bipolar. That's usually the splenic marginal zone lymphoma, or SLBL as it is called. SLBL as it is called. A hairy cell variant will have prominent nucleolus and may not have a bipolar kind of a thing. So bipolar ones are the ones that are the SLBL, splenic lymphoma with villus lymphocytes. Okay. So CLPD mimics are quite a few. CLL, follicular lymphoma, mantle lymphoma, leukemia, hairy cell, splenic lymphoma, and other NHL spills often can make it. Okay. Who am I? Born in Jodhpur, 1932. He was the president of American Society of Hematology. Has done contributed. Anyone? How do you state CLL?
Ryan Bennett systems.
Ryan Bennett.
Yeah, Rai and Bennett are there. This is Dr. Kansi Rai. Basically, an Indian origin. Has done tremendous work on CLL. His staging is still holds true even now in the presence of that. Okay, that's Dr. Rai. Okay, the penultimate case. We had a 24-year-old lady, primary gravitas, CBC for antenatal. So routine checkup. She did have some amount of menorrhagia that she could complain of. Platelets were 35,000. Right? Who's taking up? Who hasn't answered, by the way? I've not heard much from Varsha, Vasundhara. Okay, do it, Vasundhara. Come.
So there's thrombocytosis.
There's thrombocytopenia, right?
Thrombocytopenia, sir.
What do you see in the smear?
So hemolytic hemochromic RBCs, and we see hypogranular large platelets, sir.
Okay, you see hypogranular, large platelets. Okay, they are almost what in color?
Gray in color, sir.
Gray in color. So your diagnosis is made. Huge platelets. Again, some more pictures. Otherwise, RBCs and WBCs look okay.
Yes, sir.
So counts manually, if you do the count, it may not be 35,000. Okay, the counts are pretty big. They are large, hypogranular, gray forms. Okay, and this is an incidental finding that this lady had. Some more from oil immersion to the same case. The platelet distribution curve was haywire. Right? There was an upper discriminator error because those large platelets all got into the RBC. So mega thrombocytes, normal, these values you may try and remember. NPV and large cell ratio is roughly about 15 to 20%. So these are conditions where you see giant platelets. Acquired, most of the time ITP, dengue, degenerating following chemotherapy, you do get giant platelets or large platelets. There's an entity called Harris syndrome, constitutional, usually in the Eastern Indian population, Bengalis have this constitutional mega thrombocytopenia. They're otherwise asymptomatic. But such large bizarre platelets are a part of your inherited disorders of platelets. You don't get that such bizarreness or such grey color in ITP or dengue, etc. So most of the time it's grey platelet syndrome. You can get giant platelets in Bernard-Solier syndrome or May-Hegglin anomaly. Okay. So what do you think? This is the electron micrograph of platelets. Which is normal, which is abnormal?
Right one is normal and left.
Right.
B is normal. This is the normal granularity of the platelets. The granules. This is deficient. Okay. So this particular one, grey platelet syndrome, is an autosomal recessive disorder and of the alpha granules. And often they present with mild to moderate thrombocytopenia with mild to moderate bleeding tendency. Often they have menorrhagia. This particular disorder often ends with myelofibrosis and splenomegaly, the grey platelet syndrome. And supportive, and if the spleen is big, even splenectomy has been recommended. Okay, some pictures of giant platelets. What do you think this is? Anything, any abnormality you're picking up apart from the large platelet? Can you see the WBC? What does it show? I'll show you another one. Yeah.
Bilobated, sir.
Yeah, okay, fine. This is not bilobe. Something is there. Look closely.
Those what is it?
Large platelet, body. What's the diagnosis?
May-Hegglin anomalies.
Fine. May-Hegglin anomaly. These could come as spotters. I mean, I'm not sure if someone would give you a slide because it will be difficult to hunt for all these in 5 minutes. So that's the general dictum when you're given a slide. Usually you're given classical slides where you'll be able to pick up the findings in the time that is allotted to you for a slide test. So keep that in mind. But these could be spotters. These could be there. So this is Mayhew anomaly. So always cross-check platelet counts, especially when there is thrombocytopenia. That's a very important dictum. Look at the edges and tail of the sphere for platelets. Look for platelet counts. One big clump of platelet is enough to label it as an adequate platelets. Okay. Platelet color and granularity are important clues regarding their function. Okay, the last case. Who's doing it?
Also, the good news is the match is going to start, and I think India is going to bat. So if you can take 5-10 minutes,
yeah,
start in 15 minutes.
I can watch the match. Yeah, I'm getting through. It'll be over soon. Okay, anyone?
Sir,
What's your diagnosis?
so malarial parasite.
Malaria parasite present.
Just malarial parasite present will not do that. Not in your MP exam. You will have to sometimes.
Ring
Ring forms of
Which species?
Falciparum.
Yeah, so that's a diagnosis. Just you will not escape by just saying MP positive or something. So falciparum ring forms, right in this slide. Yeah, another one, falciparum ring form. Why do you call them falciparum? Why not bivax?
Single.
Looking RBCs.
Single,
The RBCs
small,
are
very small. The RBC size is normal.
it's
But
normal,
it has
yes.
many granules. It's a very neat ring. What is this?
Gametocytes.
This particular patient had a fever following a trek and clinically suspected to have leptospirosis. Platelet was markedly reduced. Okay. What is this?
I call
A call form. Right. A call form. You see that ring right at the edge.
H.
Okay, gametocyte and lots of rings. So when you get a case with falciparum ring forms, how do you report on the case? You say falciparum malaria positive with thrombocytopenia and something else you must add.
Malarial parasite index.
Very good. You must do the
Density.
parasite index, the density of parasite. Simple per number of RBCs that you count. You can just give a density index. Fine. Good. That's a gametocyte. What does this show?
Hemozoid pigment.
Very good. You picked up hemozoid pigment, brownish black pigment. That often gives you a clue. You're looking at a case for fever, and you're finding this. Look for parasites. You're bound to find parasites. This is the hemozoid pigment in the WBCs. Okay, right. Parasite and WBCs. So that's the falciparum ring. Small ones. The RBC size is not altered. You can have multiple rings. Mind you, you can have multiple rings in vivax also. That doesn't mean anything. But look at the size of the RBC and the size of the ring. This is a vivax ring. That's a vivax ring. That's a vivax gametocyte.
Increase in the size of RBC.
Yeah, all of them are increased in the size. There is a reticulocyte response. Or in fact, the vivax malaria infects the reticulocytes. Falciparum can infect all organisms, all sizes or all stages of RBCs. That's why falciparum is more dangerous. What is this? What are the species of malaria that are common?
Vivax.
Falciparum,
Malaria
and malaria.
and next one?
Ovale.
No, let's see. That is coming up in a slightly larger way. Malaria.
Ovale, sir.
So there is ovale, malaria. Ovale and malaria are usually not seen in India. Falciparum and vivax are endemic in India, and knowlesi is somewhere it was in the Southeast Asian, but we are getting cases of Plasmodium knowlesi. Plasmodium knowlesi mimics. It can be like a vivax, it can be like a falciparum, but it has this kind of schizont which is rod shape or bar shape. It goes across the RBC. So this is a clue to the fact that heterogeneity of the appearance of the ring forms and the schizonts is usually knowlesi. Okay, we are off late getting very, very less amount of smear positive for malaria. I don't know how it is in your cases. We hardly ever get a malaria positive case. I mean, hope malaria is going away. And what is this then?
Maltese.
Multiple
Malaria, that's babesiosis. This one?
Microfilaria.
Such thin, friendly. Anyone?
Yeah.
That's borreliasis. Okay. This is malaria. This is microfilaria. This?
Artifacts.
Very good. That's an artifact. Either a fungus or a cotton thread, all that. That's a mimic. What's this?
Basophilic stippling.
Very good. That's stippled RBC. That's not a malarial parasite.
Triple RBC.
This one? Is that a ring?
No.
A parasite? That's a cabo ring, not a parasite ring. Okay, so these are all potential pitfalls or mimics that you could mistake with. So again, possible questions. What is a thin smear? What is a thick smear? An old examiner is already fond of asking this. You must know the various species and the stages and partly their life cycle. If falciparum, you must know parasite index. What are the other hemoparasites? What are the microorganisms? And also important is when you're looking at falciparum, you must know why falciparum is more dangerous. What would be the autopsy findings of falciparum? Okay, malaria patient, what all would you find in the autopsy? What would you find in the brain? What would you find in the liver, spleen? So these could be possible questions. Be aware of the artifacts, and also this is important. The current way we diagnose malaria, including automation. Automation in how is in a cell counter? Can you pick up malaria by looking at the histogram or the scatter plots? So these are possible questions that come. Clinical manifestations, etc. Okay, QBC, the various start tests that are available. So all these things you must know when you are dealing with a case of malaria. All right. The last clue, correct. That's gin, and that's a photograph. What's happening? This was First World War. The story from World War I. Connected to gin and tonic.
Malaria.
Yeah.
Malaria.
Quinine was given. It used to be called the quinine parade. Quinine was so bitter that the soldiers would refuse to take it. So it was mixed with gin. Gin and tonic. That's one of the things that we have. The tonic part is the drug. So it was mixed with gin, and the soldiers were served every day one little scoop of gin and tonic, and that's malaria being treated. And hopefully we'll see the end of malaria very soon. All right. All right. So any questions in the chat, or I'll stop my sharing the screen. These are again taken from routine peripheral smears. The cells tell you that they love you when you're looking at them carefully. Okay, and they smile also. All right, I'll stop sharing the screen. And I believe there are a couple of questions in the chat box, quite a few. But anyone has any queries which we can tackle? It's quite late in the day, and the cricket match awaits. Like, I hope all of you go and watch the match and celebrate.
Yes, sir.
Yeah, any particular questions, Dr. Ruchi or something?
I think Basu, excellent discussions. 2 hours. Mehmet, you covered so much. I can't believe it in these 2 hours. It's very, I'm sure students must have learned so much.
Yes, sir.
If there's any burning question,
any burning question, please.
Otherwise,
I mean, you could send me the questions, we could get back and
yes.
And I'm sure I did see Dr. Prasad Dange answering quite a few questions on my behalf. Thanks, Prasad.
There are questions in the chat box, but somebody was answering somebody's question. It's perfect. But if these students have any burning question to Dr. Basu, or otherwise we can call it a day.
Call it a night. Right.
Or you have to watch a match.
Yeah, all of us, I think.
Thank you, sir. Thank you very much, sir,
Yes,
for the variety of cases, right from anemias to leukemias to parasites, everything covered beautifully and nicely,
Yeah,
sir.
all these are potential cases that can come up. You know, hematology, not too many. Just we go round and round the 3 cells and make life miserable. All right. Thank you very much.
You still have Basu 152, attendees in the room. It was after long.